Establishing core stability in rehabilitation. What exactly is the core? This includes the lumbo-pelvic hip complex. This is the location of our center of gravity, also known as COG. There are 29 muscles that attach to the core. An efficient core allows for the maintenance of normal length tension relationships, the maintenance of normal force couples, the maintenance of optimal arthrokinematics, optimal efficiency for the entire kinetic chain during movement, including acceleration, deceleration, and dynamic stabilization. And it also includes proximal stability for the movement of the extremities. The core functions as an integrated functional unit. The body is all connected, and the entire kinetic chain operates synergistically. The core efficiency enables structures to operate optimally. It helps us to distribute weight, absorb force, and transfer the ground reaction forces. The core requires training for optimal function. Core stabilization training concepts. We have spinal stabilization and neuromuscular efficiency. Spinal stabilization must be adequate to effectively use strength and power, and neuromuscular control and endurance of the prime movers. If we have a weak core, this will result in a decreased force production and efficiency and could ultimately result in injury. This gives us a protective mechanism for the spine. Spinal stabilization is a protective mechanism for the spine. It helps facilitate a balanced muscular functioning of the entire kinetic chain. With enhanced neuromuscular control, it provides for a more efficient body position biomechanically. For neuromuscular efficiency, this is a combination of postural alignment and stability strength. This optimizes the body's ability to generate and adapt to forces. Inefficiency results in the body's inability to respond to demands. This may result in decreases in the ability to maintain the appropriate forces and dynamic stabilization of the kinetic chain. It could also result in a compensatory action and increased mechanical stress on the contractile and non-contractile tissues. This could result ultimately in repetitive microtrauma and a faulty biomechanical process and ultimately injury. The review of functional anatomy. This includes the lumbar spine muscles such as the transversospinalis group, erector spinae, quadratus lumborum, and latissimus dorsi. The hip musculature, including the gluteus maximus, gluteus minimus, and psoas, and the abdominal muscles, including the rectus abdominis, external oblique, internal oblique, and transverse abdominis. Let's break these down a little further, starting with the lumbar spine muscles. This includes the transversospinalis group. Weakness in this group may result in poor mechanical advantage relative to the movement production. This is good for stabilization. A strong transversospinalis muscle group is good for stabilization. We want optimal muscle tone for providing proprioceptive information to the central nervous system. Intra and external segmental stabilization occurs here. The multifidus is one of the primary transversospinalis muscles. The erector spinae provides intersegmental stabilization. It eccentrically decelerates the trunk flexion and rotation movements. The quadratus lumborum is a frontal plane stabilizer, and it works in conjunction with the gluteus medius and tensor fascia lata. The latissimus dorsi bridges between the upper extremity and the core. Next, the hip muscles. We have the psoas. The psoas functions differently in closed chain versus open kinetic chain functioning. It works with the erector spinae, multifidus, and deep abdominal wall to balance the anterior shear forces of the lumbar spine. The psoas can reciprocally inhibit the gluteus maximus, multifidus, and deep erector spinae, as well as the internal oblique and transverse abdominis when it is tight. This results in an extensor mechanism dysfunction. Synergistic dominance in the psoas occurs during hip extension. The hamstrings and superficial erector spinae may be activated, and it may alter the gluteus maximus function, altering hip rotation and ultimately the gait cycle. The gluteus medius functions as a frontal plane stabilizer. Weakness increases frontal and transverse plane stresses and may result in patellofemoral stress. This controls the femoral adduction and internal rotation. Weakness in the gluteus medius results in synergistic dominance of the tensor fascia lata. This could lead to tightness in the IT band and the lumbar spine. The gluteus maximus performs hip extension and external rotation during open kinetic chain exercises concentrically. Eccentric hip flexion and internal rotation can occur as well. It can decelerate the tibial internal rotation with the tensor fascia lata, and it stabilizes the SI joint. Faulty muscle firing of the gluteus maximus can result in a decreased pelvic stability and neuromuscular control. The hamstrings concentrically flex the knee and extend the hip and rotate the tibia. When they contract eccentrically, they decelerate the knee extension, hip flexion, and tibial rotation. They work synergistically with the ACL to stabilize tibial translation. All of these hip muscles produce and control forces in multiple planes. The key to providing dynamic stabilization and optimal neuromuscular control is here. Synergistically, these muscles work together to enhance stability and function through the entire kinetic chain. The abdominal muscles include the rectus abdominis, external obliques, internal obliques, and transverse abdominis, also known as the TA. These muscles all work to optimize spinal mechanics. Together, these abdominal muscles work to optimize spinal mechanics. They provide sagittal, frontal, and transverse plane stabilization. The transverse abdominis muscles work to increase intra-abdominal pressure, to provide dynamic stabilization against rotational and translational stress, to provide neuromuscular efficiency and a feed-forward mechanism, and to stabilize the trunk prior to extremity motion. The transverse abdominis and the multifidus, their role in core stabilization. The transverse abdominis serves as a trunk rotator. It helps to increase the intra-abdominal pressure, thereby increasing spinal stiffness. It also reduces laxity at the SI joint. The thoracolumbar fascia. Contractions of the transverse abdominis and pull on the thoracolumbar fascia causes spinal compression to increase intra-abdominal pressure to increase spinal stability. Collectively, stability is enhanced via interplay between the transverse abdominis, the intra-abdominal pressure, the thoracolumbar fascia, and compression of the SI joints. The multifidus is the most medial of the posterior trunk muscles. It is a stabilizer when the trunk is moving from flexion to extension. The primary role of the multifidus is to engage in postural stability. It is active during all anti-gravity activities. The transverse abdominis and the multifidus contract collectively to generate girdle-like muscle support. The transverse abdominis and the internal oblique muscles contract in a feed-forward mechanism prior to limb motion. The pelvic floor muscles contract, resulting in increased intra-abdominal pressure and thereby increasing the lumbopelvic stability. By submaximally contracting the pelvic floor, we may be able to isolate contractions of the transverse abdominis. Postural considerations. The core functions to maintain postural alignment and dynamic postural equilibrium. Optimal alignment results in optimal functional training and rehabilitation. Segmental deficits result in predictable dysfunctions. There are serial distortion patterns. Structural integrity of the body can become compromised due to malalignments, and abnormal forces are then distributed above and below the misaligned segment. As practitioners, we need to work to maintain alignment and integrity of the kinetic chain. Muscular imbalances. A balanced core results in prevention of muscle imbalances and synergistic dominance. This allows for optimal neuromuscular efficiency. Pathology within the kinetic chain is part of the chain reaction, and we result in a compensatory reaction of the kinetic chain. Muscle tightness or weakness can result in changes in the length-tension relationships, changes in force couples, altered arthrokinematics, and reciprocal inhibition, which facilitates the muscle imbalance. Muscle imbalances can occur throughout the lumbopelvic complex and may impact the entire kinetic chain and impact stability. Substitution patterns develop to compensate for a lack of stabilization. This is also known as a cross-pelvis syndrome. Weak abdominals and glutes are often compensated for with tight hamstrings and hip flexors. A strong, neuromuscularly efficient core can help to prevent the development of muscle imbalances. This provides a stable base from which the extremities function maximally. Some other neuromuscular considerations. Enhanced dynamic postural control can happen with a strong, stable core. Anytime we have a kinetic chain imbalance, we result in a deficient neuromuscular control. For example, the impact of low back pain on neuromuscular control. Also, after a joint or ligament injury, we may have neuromuscular deficits. There is an arthrokinetic reflex. This is a reflex mediated by the joint receptor activity. The altered arthrokinematic reflex can result in arthrogenic muscle inhibition. This results in disrupted muscle function due to the altered joint functioning. The scientific rationale for core stabilization training. We must train at an adequate level. We need to balance between too much and not enough. Injuries can disrupt muscle function, such as low back pain. Training with muscle deficits leads to the development of muscle imbalances and inefficient neuromuscular control in the kinetic chain. Appropriate training stimulus must be prescribed. The time under tension for the muscles must be at least 6 to 20 seconds. The speed of the motion for each exercise should be considered. Decreased cross-sectional area of the multifidus in the low back patients. Spontaneous recovery of the muscle does not occur, so core training is necessary to get this muscle back online. Curl-ups increase intradiscal pressure and lumbar compressive forces. The drawing in maneuver should be initiated prior to core training. This results in increased EMG activity and pelvic stabilization. We want to maintain our cervical alignment during core training as it improves posture and muscle balance and stabilization. The assessment of the core. The 7 core base myoactivation movement tests and additional basic movement tests can be used in the myoactivation assessment. Each movement test is labeled at the top with its abbreviation in purple. The purpose of each test, including the muscle groups evaluated, is indicated in the red text at the bottom. This is one example of a core assessment. Through this core assessment, we must identify muscle imbalances, arthrokinematic deficits, and the core for strength, endurance, neuromuscular control, and power. The overall function of the lower extremity kinetic chain, we may need to use assessment tools such as activity-based tests, EMG with the surface or indwelling electrodes, and ultrasound. Here is one example of a lower extremity core test. This is the straight leg lowering test for core strength. This is useful for quantifying the strength of the lower abdominals, the rectus abdominis, and the external obliques. Another test is the prone transverse abdominis test. This can be used to assess the coordinated transverse abdominis and multifidus function. The patient maintains and then slowly releases the drawing in maneuver while minimizing pelvic and spinal movement. The spine transverse abdominis test. This is similar to the prone test. The athlete performs a drawing in maneuver, and the patient will maintain pressure for a minimum of 10 seconds. We can monitor the drawing in of the abdomen as opposed to pushing out of the abdomen, signaling internal oblique activation. Neuromuscular control of the multifidi. The patient breathes in and out and then holds their breath to swell out the muscle under the fingers. The patient lies prone while the clinician monitors the multifidus activation. The patient breathes in and out and then holds their breath to swell out the muscles under the finger. The patient contracts the multifidus while the clinician monitors the contraction during normal breathing. Compensations may occur, such as an anterior or posterior pelvic tilt or elevation of the rib cage in an effort to swell out the multifidus. A training program must be scientific and systematic in its pattern, aimed at training trunk stabilizers in all phases of functional tasks. This should include everything from a simple static posture, such as standing or sitting, to highly complex tasks, such as high-intensity athletic skills. Patient education is critical. We must be able to visualize the muscle activation. They must have body awareness to activate the core muscles with the proper positioning, neuromuscular control, and the force necessary for each task. Performing the drawing in maneuver, the pelvic tilt. This is done with submaximal abdominal hollowing with trunk bracing. We pull the navel towards the spine while stabilizing the body in the trunk. The maneuver should be maintained during all exercises. We need to continue training the transverse abdominis and the multifidus in other positions. Once we have mastered the pelvic tilt, we can progress our patient to quadruped activities in which the patient is on their hands and knees. The effect of the pelvic tilt and knee and hip hyperextension on lower body posture. We can see these different types of postures, everything from a lordotic back, a flat back, a sway back, and a balanced posture. All of these muscle imbalances must be addressed in our core stabilization training program. Level 1 stabilization. Here are some examples of some training core exercises. Level 2 focuses on the strength of the core stability exercises. For many of these exercises on this screen, we have the Swiss ball that helps make the strength exercises a little bit more complicated. The next level is a power phase for core stability exercises. This includes more dynamic types of exercises. Core muscular endurance and power. For endurance, we need to focus on the erector spinae performance. The athlete may be prone with their hands behind their head and the spine is extended up to 30 degrees. We can measure the ability to sustain this posture with a goniometer. We can use the axilla and the table for the frame of reference. We then can test the individual for their performed time. For power, we could do backwards overhead medicine ball jumps and throws. This can be an assessment of the total body power production. For lower extremity functioning profiles, we can use isokinetic tests, balance tests, jump tests, power tests, and sport-specific functional tests. The kinetic chain assessment must address all areas of potential deficiency. The guidelines for core stabilization training. We need to perform a comprehensive evaluation. We need to look at program requirements. Are they systematic, progressive, and functional? Focus on the entire muscle contraction spectrum, the force production or concentric contraction, the force reduction, eccentric contraction, and the dynamic stabilization, isometric contraction. The program must also be challenging with progression through functional continuums. Variables must be modified, including the plane of motion, the range of motion, the loading parameter, the body position, the speed of the movement, the amount of control, the duration, and the frequency. The guidelines. The goal of the program should be to develop optimal levels of functional strength and stabilization. We should have a proprioceptively rich program. It needs to be safe, challenging, stress multiple planes, incorporate multiple sensory environments that are derived from fundamental skills of movements. There needs to be activity-specific and progressive functional continuum. We need to progress from slow to fast, simple to complex, known to unknown, low force to high force, eyes open to eyes closed, and static to dynamic. The goal of the program, again, I need to reiterate, should be to develop optimal levels of functional strength and stabilization. Focus on the neural adaptations instead of the absolute strength. Increase proprioceptive demands. Focus on quality, not quantity. Poor technique and neuromuscular control results in poor motor patterns and stabilization. The focus should be on function. Is it dynamic? Is it multiplanar? Is it multidimensional? Is it proprioceptively challenging? Is it systematic and progressive? Is it based on a functional anatomy and science? And is it activity specific? Start with the drawing in maneuver. Abdominal endurance with trunk stabilization can enhance function and may prevent injury. The trunk must be dynamic. It allows for multiplanar movement at varying speeds while maintaining internal stability and a strong base of support leading to functional mobility. The clinician must be creative when designing a program. Programs must be individualized to the patient. We must integrate individual exercises into functional patterns, progressing from simple to complex or high level to meet the patient's needs.